Hello, everyone. Hopefully you can hear me. Welcome to our webinar. The subject today is hospitals and supply chains in view of COVID-19. My name is Alex Efron. I'm a second-year MBA student at Columbia Business School and co-president of the Healthcare Industry Association. Thank you all for joining us today. I'd like to take a moment now to introduce all of our panelists today. Hopefully you can see them as well. Our first panelist is Professor Carri W. Chan. She is an associate professor in the Decision Risk and Operations Division at Columbia Business School. Her research focus is on using data-driven modeling to improve healthcare operations. She has done extensive work in the space of ICU management and has worked with numerous clinical collaborators. Professor Chan has been spending the past year on sabbatical as a visiting researcher at the New York Presbyterian Value Institute, which sits between analytics and quality within the hospital. Professor Awi Federgruen is the Charles E. Exley Professor of Management and Chair of the Decision Risk and Operations Division at Columbia Business School. He is a world-renowned expert in the development and implementation of planning models for supply chain, revenue management, and logistical systems. Dr. Joel Park is an Assistant Professor of Clinical Emergency Medicine at Weill Cornell Medicine and is a clinical data scientist on the New York Presbyterian IT transformation team. He did his residency at the Columbia University Medical Center. Dr. Park has been working on the front lines at the Cornell ED and is here to share the perspective of a provider from within one of New York's largest hospital systems. So just to give everyone a little bit of an overview of the format today, we're going to be going through our panel for the next approximately 25 minutes, and then we'll leave about 15 minutes for audience Q&A. If you see at the bottom of your screen, there should be a little button that says Q&A. Please submit your questions there for the session at the end. So first, I'd like to go around to our panelists so that they can provide a little bit more background on themselves. So I'll start with Professor Carri Chan. Can you provide a brief introduction about the work you do and how it relates to or is impacted by the current crisis?
Great, thanks, Alex, and thanks for all of you for tuning in. So as Alex mentioned, my research is in healthcare operations management. And so at a high level, what I do is I spend a lot of time trying to understand how to manage the limited resources in a hospital system to improve patient flow. And I've looked at this particularly in the intensive care unit to try to understand what is the impact of congestion on the access to care for patients and what this means in terms of their outcomes. And as I'm sure many of you have been noticing in the media, many of the patients with COVID end up in the ICU having respiratory issues. And so a lot of the work that I've been doing tries to understand how we can allocate this limited resource and to do the most good and to improve the flow through the ICUs when we know that capacity is such a big issue. So some of the things that I've been doing over the past couple of weeks, as Alex mentioned, I'm doing my sabbatical at New York Presbyterian in their Value Institute. And so I've been trying to use data analytics to understand better models of demand for patient need. How do we think about resource allocation in these particular settings? And how can we use it most effectively to try to improve as many outcomes as we possibly can? So I'm looking forward to sharing more of my thoughts with all of you today.
Thank you, Professor Chan. Would you like to go next, Professor Federgruen?
Sure, thank you. So a good part of my research certainly over the last several years, over the last 10 years and so on, has been on the topic of how to deal with various forms of supply risks and supply disruptions and how to be prepared for them. I think one of the big issues that we're facing in the current crisis, that as a country, we've been grossly unprepared for this onslaught. And also various companies in their general supply chains faced problems and are facing problems because they aren't quite properly prepared. So a good part of my research over the last 10 years has been dealing with these issues and setting up planning models on how one can properly protect oneself against these possible risks, what one should do in terms of diversification among suppliers, and what kind of contractual arrangements make sense in a world in which there is increasing uncertainty. I also happen to have worked specifically and quite intensively on a project that deals with the global vaccines and the chronic shortages, actually, not just the current shortages, but the chronic shortages that exist for these very, very vital vaccines, and what to do about them, what the root causes are, and how we can cut through these chronic shortages by coming up with novel arrangements between the manufacturers and the purchasing organizations. So as such, I'm on a worldwide think tank that tries to prevent a new outbreak of polio, for example, which could be as severe in the world as what we're experiencing now, maybe more severe.
Thank you.
I'll leave it at that for now.
Hi. So to give you a little bit of background about myself, so I'm predominantly an emergency medicine physician. I'm a clinician first. So I had the opportunity to be working predominantly at Cornell Medical Center as well as Lower Manhattan Hospital, and has been treating patients that predominantly actually has only been mostly COVID. I think majority of the patients are actually not, with other complaints, are actually not coming into the emergency department. But during this time, I've been working with our emergency department leadership, who they've been working in conjunction with the rest of the different hospitals across the New York Presbyterian hospital system. I've been working on the back end with the analytics team. That's the team that Carrie has been on, and help kind of translating some of that data over to the ED leadership to help make decisions on some of the tougher decisions, like on patient care. So as we know that there's a lot of there's a limited resources when it comes to like patient beds, inpatient units, step-down units, ICU units, as well as PPEs, ventilators, and all those kinds of things. There has to be a decision that's made with guidance from data. And part of the work is trying to understand what the problem is, what the data shows, and then acting on it, so that way we can best optimize our care for every patient around. So it's been an interesting time, but there's been a lot of work that's been going on both on the front end and the back end.
Thank you. Well, so many of us are really just reading the headlines and following along. So it's helpful to have some folks on the ground who can keep us informed. So my first question is, what is the current situation at the hospitals? And can you explain what the capacity situation is, and what have some of these hospitals been doing to prepare for this increase in demand? I'll start with you, Dr. Park.
So I think when we first read on the newsline, when the first patient came to Columbia University with the first COVID patient, I think the majority of us knew that something was coming, but at this time, it's like many other places, we probably were thinking about it, but didn't realize, how quickly it was going to come and hit us. And as the number of cases has risen exponentially, the changes in the way we operate and we take care of these patients has changed almost on a nearly daily basis. So the hospital's gotten very quick, as well as our department, on thinking about how many patients. At first how do we test these patients? Who should get tested? Who gets admitted to the hospital? And at first the answer was, as we always did, if we felt from a clinical perspective they should be admitted to the hospital. Now, as cases rise significantly, there becomes a limitation of the number of beds, as well as the number of PPEs and the ventilators. While the hospital leadership has done a great job trying to allocate the resources to help anticipate some of the needs that may be occurring, it is on our mind in terms of, thinking about, from the clinical end, like, what patients should stay in the hospital, what patients should be going home. So from the clinical perspective, while, while we're using the resources and we're using a lot of the work that the analytics team has been providing, we've been also trying to decide on what are some interventions that we could do to help, improve the capacity that we have. So ramping up telemedicine, for example. So we've been seeing a 10 times increase in the telemedicine visits. we've been talking about changing some, we stopped elective cases, and we've been expanding some of the units to be ICU units, and looking at our suppliers to help expand like ventilators and PPE. So there's been, right now, currently, I can only speak from the Cornell capacity as well as the Lower Manhattan capacity. The situation, we're not at max capacity, but I think that's probably because we've been working, the hospital itself has been working very rapidly so that we don't hit that ceiling, making difficult decisions on who to intubate or not intubate, and a lot of those medical ethics that many of us, aren't really necessarily that are willing to or excited to make those kind of choices. So that's what we're kind of going through at the moment. It's been interesting times.
Building a little bit off what Dr. Park was talking about more broadly of what's been happening across NYP and other hospitals within the New York system, I think that in February, when the first case came out, and I think it, as Dr. Park noted, we knew something was coming, didn't know that it would grow so rapidly, but there were a number of actions taken to prepare for this. So canceling elective surgeries, moving to telemedicine, to just open up capacity where it's possible. But even beyond that, so that's using the resources that are currently available, but actually flexing up capacity even further. So, some operating rooms have been turned into ICUs to make space for more patients. I'm sure that many of you have seen that there's the Javits Center that has been opened up in New York, and now is actually going to be taking COVID-only patients to help with this increase in demand. And so there's also field health hospitals being opened. Different hospital systems are opening up in different places. And so there's been a lot of efforts by hospitals to expand capacity. My understanding is that, especially within, for instance, NYP, it hasn't gotten yet to the point where the capacity limits have been hit, and that's because all of these efforts by leadership have been taken into consideration. But more needs to be done, because if we don't slow down the growth, we could get to the point. We're not there yet, and we want to try to avoid getting there. So there's a lot of efforts. There's questions also about who can be treated where. I think one of the nice things within New York Presbyterian is there's many different hospitals, and I know that there has been transfers of patients across hospitals when necessary, and the governor of New York has also been trying to make sure that harder hit hospitals get the resources that they need. And so it's really about, it's a collective effort now to try to manage this. And a lot of the research that I do highlights the implications of congestion and this lack of access to care. And I think intuitively we all know that it's not good if you can't get timely access to care, but the data shows it as well. It shows itself in terms of increased risk of bad outcomes, increased risk of length of stay. And when we are in a capacity constrained environment, we can't afford to have longer lengths of stay because we weren't able to get care in a timely manner. And so it's so important that all these efforts are being done. And I'm encouraged by the fact that, hospital leadership is doing it, but we can't relax. We got to keep going forward.
Thank you both. I think that helps lay the groundwork and set the context for some of these next topics of discussion. I want to talk a little bit about research here for these professors here. From your research, can you talk a little bit about any strategies that hospitals can utilize now to navigate the current situation or in the future to better handle it? This could be either from the delivery side of things or the supply chain management perspective. I'd like to start with Professor Federgruen.
Okay, so let me leave the hospital operations side to my two dear colleagues, and indeed focus on the supply chain issues. At this point, everybody's just trying to catch up and to get the ventilators and the protective gear in whatever amounts are available, knowing that it's not going to be sufficient and in an incredibly difficult environment. Hopefully, we will learn the lesson from this experience. This is unlikely to be the last time in human history where we're going to be confronted with a crisis of this type or a pandemic of this type. And there are certainly ways to be made much, much better prepared. It is not reasonable for hospitals to, on an individual basis, to carry the kinds of, we might refer to as safety stocks of any one of the items that we mentioned, whether it be ventilators or whether it be protective gear, that is sufficient to cover these extreme situations. Hospitals are operating in a very competitive environment, operating with very small margins, often having a difficult time balancing their budgets and remaining in the black numbers. It's just not reasonable to put that onus, certainly not exclusively and not even primarily on the hospitals per se. So we need to have a system on a nationwide basis that creates these kinds of national stockpiles. And we need to do a much better job about that. We have grossly failed in there. To enter this situation with a national stockpile of some 12,000 or 12,700 ventilators is just unconscionable, I would describe it. We can argue about models and and even models as they would have been designed several months ago, or even a couple of years ago. But anybody preparing for a pandemic should have known that the needs are going to be way, way higher, and should have prepared for it, and should have should have built the kind of inventories, and on top of that have the arrangements. Fast arrangements with suppliers that would enable to produce it. The frustrating thing that I guess we're all experiencing is that now that we know what we need, it's so hard to actually get to that point because the capacity is simply not available. And what we're saying about ventilator supply is just as much on protective gear and everything else that is needed, and is so essential. And this has to be done on a national basis and thought out on a national basis, not even on a state basis, on a national basis. The investment that is required is significant, but it is a drop in the bucket against all the losses and economic, and I'm talking about economic losses. I'll leave the other side to my dear colleagues to talk about the economic losses that we're all undergoing right now. And there are ways to do it. It's not, it's really, it is science, but it's not rocket science.
Thank you.
So maybe I'll talk a little bit from the delivery side of things. As I mentioned earlier, so I've done some work that has demonstrated the adverse effects of delay in access to care. And so trying to understand and better mitigate that, I started thinking about the alternative, which is actually giving proactive care. So maybe giving care to patients before they deteriorate, before things get too bad. The benefit being that potentially you can utilize fewer resources to bring the patient back to a stable level and to be able to discharge them earlier using fewer resources. The drawback being is that if you're giving everybody care that may not need it in the future, you're using up these expensive resources and potentially limiting the ability to give it to severe patients that are arriving. And yet, my research has found that there's kind of this sweet spot. If you can identify the most at-risk patients, that you can, even if you're taking a bet, because there's some probability that they will not ever need to go to the ICU, for instance, but there's still some high level of risk of that happening. The benefits that you get in terms of reducing their mortality risk, the benefits that you get in terms of reducing their length of stay once they finally do receive care, will outweigh the small increase in occupancy you may incur for admitting those patients in this proactive manner. And so, you know, in kind of normal times in the hospital, I've found that if you can do this type of proactive care for the top 5 to 10% of patients, you can dramatically reduce mortality rates by a factor of 4, and you can reduce without dramatically increasing occupancy. Now, is it possible to do it in the current situation? Well, I think it's challenging because we're right now in the situation where we're, especially in New York, where we're just trying to manage with the demand that we have. We don't have excess capacity, but there are places, other places within the country that don't have as much demand, and they have the ability to possibly give this earlier access to care. And in fact, there's data coming from Wuhan, China, that shows that there are patients who are positive but are not sick enough to go into the hospital. They're being monitored in these centralized quarantine facilities with very limited medical staff. So they maybe are getting vital signs taken once or twice a day, their temperatures, their oxygenation levels. But because there are trained medical staff there, they can identify if that patient is deteriorating quickly. And they've found that actually these patients who are staying at these facilities have a much, much lower risk of having to go to the ICU and having a severe case of COVID. So I think that there are opportunities to leverage some of this proactive care in this particular situation, particularly in locations where they're not yet creeping up to the capacity limits.
Great, thank you. I'd like to follow up and dig a little bit deeper onto the subject of PPE. That's personal protective equipment such as surgical masks and N95 respirators, gowns, and gloves. First, I'd like to ask Dr. Park, what's the current situation in your hospital? How are your colleagues equipped in responding to some of these shortages?
Yeah, so I think for the most part, again, at Cornell, we've been doing okay with our PPE in terms of having enough supplies, but that doesn't mean that we are not reusing some of the equipment that we have. So there are different types of protective equipment to different types, and I'm sure you guys have heard like in the news, like the N95 masks versus the surgical masks versus the gowns and the eye protection. So the hospital itself has given us guidelines on typically a lot of these PPEs are only one-time use and you shouldn't be using it more than once. But given the current situation, we've been given some instructions on how to reuse them, such as like giving us goggles, and they've been teaching us how to wipe them down, and so we can use them between cases, reusing the N95 masks throughout the day. We haven't gotten to the point where we actually have to keep them for like a week, like you've been reading in like some news sources where they've been reusing over and over again. But we've been actually come to a point where we've been pretty creative with some of our colleagues at the Department of Engineering, both up at Columbia and at Cornell, where they've been 3D printing face shields for us. And we've been using them like the welder style face shields, and we've been able to use them. So while I don't really know like the back end of the supply chain of how they're bringing up from the warehouses over to us, I do know that for us, PPE tends to be a very popular thing to have, and may be prone to theft and stealing. So usually what happens is that the source of the PPEs are in the watch of the team leaders or the charge nurses, so they keep charge of who's taken it, if it's being used appropriately, and making sure that that we're not unnecessarily wasting PPE. So again, I think from the preparation, like Carrie was talking about, from the senior leadership and anticipating some of the shortages that we may encounter, we haven't really run into too many issues with the PPE. Now, there may be some disagreements on what constitutes a PPE amongst individual staff members. Some people may feel that we need the big suits and those kinds of things, but there's been a standard approach through the infection control that deemed like the standard PPEs that they've been able to provide for.
That's very helpful. Just to bring it back to Professor Federgruen, on the side of production, we've certainly been hearing about a lot of non-healthcare companies springing into action to develop their own masks and N95s and even some ventilators. But can you speak a little bit to why we can't, as a country or even as a global supply chain, just quickly produce the masks and the ventilators that we need now? What's the delay? What kind of lead times are we looking at?
Yeah, those are excellent questions. And they're not well understood, not even among the people who are trying to manage the situation. And a good example was when our president became very infuriated with the chief executive officer of General Motors, who is going to re-engineer some of their plants in order to produce ventilators, and not understanding why it is going to take as long as it will. The answer is that with the best of intentions, to re-engineer a plant that is designed to make cars and to now have those lines produce ventilators takes a lot of work, and particularly for an item where one has to be very careful about its design and its quality, and no mistake should be made, because you produce a defective item and you put it into operation, and it has more of a negative impact on the patient than it has a positive impact on the patient. So unfortunately, these reconversions, let me say, first of all, we should compliment a lot of companies that are going into this battle now and putting maximum efforts to do whatever they can to provide the capacity that we're missing so dearly. But it is going to take some time, and even for the General Motors and the General Electrics that are jumping in, it's going to take a couple of months before they can produce in numbers that are really going to make a significant dent in the shortage that we're seeing. We should still remember that as much as we've been through it a couple of weeks, we are only at the beginning of this problem. Unfortunately, it is likely to be with us for a good number of months, if not more. And we're going to be seeing these shortages. I want to mention this context. I know our time is limited, but I want to mention very quickly a wonderful initiative that Qian undertook right from the beginning when this crisis became very clear. Qian, as you know, is the former chief executive officer and chairman of American Express. And he started an initiative called Stop the Spread, where he invited a large number of companies to work with him on various ways and what we can do to manage the crisis. He surrounded himself with a team of analysts of various backgrounds to do various analyses to support that. One of those initiatives I had the privilege of trying to assist to actually come up with a bottom line, very detailed but bottom line estimates of what the needs are going to look like for protective gear in particular, in assuming that we want to adhere to what is the prescribed protocols for using protective gear. What we're already hearing from Dr. Park is that even in the current situation, those protocols have to be compromised, and that while the normal protocol is that gowns and so on have to be substituted after any single visit to a patient, that is a standard that we can no longer adhere to given the shortage that we have. And that's the situation today. Unfortunately, I think we're going to see bigger shortages and bigger problems and bigger compromises, and therefore bigger negative impacts on the medical care that can be provided, as well as the dangers that the health workers are going to be exposed to in the future. It simply takes time, and since it takes time, it is not something that can be left to a couple of weeks after the crisis has started. One got to prepare in advance, and that lesson is one for the country, and it's also a lesson for many companies when they face their disruptions, which may not be as dramatic as what the country is experiencing, but they're dramatic for the companies often as well. In there, it simply takes time. It is not something that can be done by snapping one's fingers.
If I could take a minute to build just one comment on what Professor Federgruen was mentioning in terms of the risk to our front line. So I created a model to just try to understand what's the impact of availability of PPE on our frontline employees, and really how this translates to the ability to treat patients. And why is this so important is that there's a lot of literature that says in such a situation, it is the staff that is the bottlenecks. Now, we hear a lot about the lack of availability of ventilators, and I don't want to minimize the importance of having ventilators. But even if you have all the ventilators to treat every single patient, if you don't have the respiratory therapists, you don't have the intensivists, you don't have the nurses to manage and monitor those patients on the ventilators, those machines are not effective in treating the patients. And so it is well documented that the staff is actually the bottleneck. And so if we cannot protect our front lines, that actually reduces our total capacity to treat patients. And so it's so important to be able to make sure that our frontline employees are being protected so that they have the ability and the help to be able to treat the patients that are coming in. And so I just wanted to highlight that of why this is such an important issue.
There's been many of us who've, a few percentages who's been inadvertently exposed and have been placed on quarantine, and it becomes very challenging for us to care for our patients if we're locked into our homes. So, we've been trying to mitigate some of those situations by having some of those doctors do telemedicine doctoring while they're quarantined in their homes. But Carrie's absolutely right. The staff can be a limitation. And even New York Presbyterian itself has even called out for other physicians outside the state to come in and credential quickly, because if you expand the ICU capacity by double, you still need intensivists to run them and to make sure that those ventilators are working and that those patients are being cared for.
Great. So on the subject of being prepared, either in this current situation or in the future, we talked a little bit about stockpiles. And I think there's often this question of where is the responsibility? Should hospitals be maintaining these inventories? Should it be done on a federal level or a state level? I was hoping you could talk a little bit more about the role of government in ensuring these stockpiles and where should the responsibility lie, and exactly what went wrong with our national stockpile of ventilators, for example.
Okay, so to answer your first question first, I do believe, while in general I believe in decentralized systems, and there are situations where centralization is really essential, and centralized decision-making is essential. And I think this is one of them. To protect for these major national emergencies is a national need. And as I mentioned earlier, it's not a responsibility on owners that we can put on individual hospitals. And it's also not very effective to put the onus on even the individual states. There are a lot of advantages for risk of this type to manage this in a pooled manner with centralized inventories. Certainly what we're experiencing now exposed that states are desperately bidding against each other, trying to find a few ventilators here and there, and are in a cruel, I would call it a cruel bargaining situation. Is something to be avoided. But even ex ante, in preparing for it, this is one of these things where we really need the government for, the federal government for. And what happened with the ventilators is a good example. It was very well understood for a long, long time that we needed a much bigger stockpile. And the government, the federal government, started a project going back more than about 15 years ago to try to develop that. But they operated at such a slow speed, and they really tried to procured these ventilators at a very low cost. Very few companies were interested in producing, particularly in those quantities at that particular price. And it just took forever. They finally made a contract with one company to produce these ventilators for them at the price of $3,000, which is way below the market price. The company did agree to it, and then this wasn't even embedded in a firm contract, so much so that the company was taken over by Medtronic. And Medtronic, seeing this obligation, was able to get out of the deal. And the federal government thought that they had a deal, but they didn't have a deal. And Medtronic, some people even argue that Medtronic bought the company so as to preserve the market value of the ventilators in there. So this has to be done on a national basis, and it has to be done by people that understand supply chain management and that understand that don't be penny wise and pound foolish, as the British would say. It may pay to pay a little bit extra because the amount that you're paying that you're extra is going to be a drop in the bucket against all the problems and the losses that you're going to be encountering if you're not protected.
Great. On the subject, so if there is the stockpile and the supply, I wanted to ask a little bit about bidding, particularly competitive bidding. It seems like from what I've been reading, we have bidding from both the federal government and individual states, as well as individual hospitals and private companies for these supplies and this equipment. Is this the process working as intended? I was hoping you could elaborate, any of the panelists, on sort of what's that process look like?
So I guess that's still in my domain. Anyone welcome comments from my colleagues, but this was certainly not intended. This is again, auctions and bidding processes. Well-designed auctions are incredibly useful mechanisms to regulate markets and to make markets clear. And but this is not a regular auction that is going on there. This has nothing to do with an auction. This is a situation where we have an incredible shortage and states having to bid against each other in a disorganized manner against each other, and then FEMA coming on top of it. We hear the governor of New York State constantly complaining about this process. This is surely not something that was intended. It's also surely not something that works, which is why it has to be, why the solution is to try to plan in advance. Even within the crisis, I think the government should be more proactive in saying, we are going to step in, we're going to do whatever we can to try to procure these things from wherever we can get it in the world. And we will design an allocation mechanism to the states that takes into consideration all the necessary factors, not just the number of cases that are out there right now, but looking into the future, where we can most effectively position the equipment so as to avoid the future and stop the future development. It's not as simple as to say, I'm going to use a rule where I'm looking at the current number of cases in the different states and I'm going to proportionally allocate whatever I have. That kind of a rule is not very effective. A lot more needs to go behind it. And that requires the exercise of some good planning models. With the help of the epidemiologists who understand what the future dynamics are, a combination, an integration of supply chain management knowledge and epidemiology.
And in fact, this centralized system is happening in a way in New York State, where the governor has decided is centralizing the use of the ventilators and moving them, has decided that he has the authority to move as necessary to hospitals that have higher demand. Now, what is necessary to have this work? Now, certainly this could be met with resistance from different hospital systems, because their fear is that when they actually need the resources, it won't be there. But if it is truly being done in a efficient and effective manner, this actually will help the overall system. Everybody will be able to get the supplies when they are necessary. But you need to trust that the centralized planner, that the government that is managing this has the best interest at heart, and that it is being done, that the right information is being transmitted across all parties. And so that, I think, is one of the biggest challenges that's facing, the country as a whole. It's in an ad hoc way. There are a lot of doctors and nurses who are coming to New York to help. The governor asked for people to come, but this is again being done kind of, mostly altruistically, although some of it is also being done through the armed forces and providing some supplies in that way.
So Carrie pointed out a very important point. Beyond doing proper planning, it's also very important to get people's trust and the institution's trust. And the way to build that trust is to actually, in times where the crisis isn't there, to indeed educate the top management of the different hospitals about what allocation strategies would look like, and why they would be designed the way they would be designed, so that people understand why, even though their hospital may represent 10% of all the cases, they're not quite getting 10% of the equipment. So education and running through scenarios and simulations is an essential part of preparedness.
Speaking of education, since this is a webinar hosted by Columbia Business School, I would be remiss to not ask about the tie-in to MBA education. I myself was fortunate to take Professor Chan's operations management course. Yet to have the privilege to take one of your courses, Professor Federgruen, but how, certainly there's a lot of focus on analytics and more advanced operations management. How is the future of MBA education tying into these sorts of challenges?
Well, I believe that these topics will continue to be, and will become, in fact, of increasing importance. And in our supply chain management courses, we talk a lot about all these issues. And that's true for my own courses. It's also true in the MBA program. It's my dear colleague, Professor Singh, who is teaching really the majority of the students in many sections, all these different issues of preparedness and how one prepares and what the different risks look like and what proper mitigation processes are, both on risk on the supply side and risk on the demand side, are the key topics in these courses. And I believe that for our MBA students, whatever career they go into, whether it be an operational career, whether it be a consulting career, or whether it be a general management career, understanding these issues is going to be crucial. So I think it will play a continuing and a growing role I believe in the MBA education.
Thank you. So I'll ask my last question before we turn it over to the audience-supplied Q&A. How should we be thinking about this situation across the country, and what can be done between now and the fall to better prepare our healthcare system for the possibility of a second wave?
I guess I could take that one. So I completely agree with what Avi said about, I think preparation is the key. I think currently New York City is at the epicenter of, I think it actually has one of the most cases around the world, period. And I think part of the work that we've done, we were doing the work on the fly. So a lot of the analytics, a lot of the operations decisions was nearly done on a day-to-day basis. And some of us were working nearly all morning, all night, all times of the hours, just trying to decide what to do with at any given moment with the information that we had. But, if other places around the country are not necessarily, they're not necessarily in this state, they should, take this time and opportunity to prepare because a lot of these different cities around the country have a lag time behind ours. So if there are about 2 weeks behind what we're facing, the way that this disease is spreading, the way we've been seeing it, as well as the characteristics of how this disease presents itself. And this is something that, in regards to, again, things along supply chain or staffing or hospital capacity or ramping up telemedicine or shutting down elective procedures. These are all lessons that hopefully other cities are taking, and that they're using this now so that when they get into this situation, which is likely to be inevitable, they will be best prepared to deal with this. So that and social distancing.
Great. Okay. Well, that was fantastic. I appreciate your response there. I know it was a bit of an open-ended question. So it looks like we've got about 15 minutes left. And so I'll turn it over to the audience submitted questions. It looks like we've gotten about 21 of them. So I don't think we'll be able to get through all of them, but we'll try to keep a quick pace to answer as many as we can. The first is coming from a fellow student of mine, Mercedes Lee. Mercedes asks or says, we've seen over 76,000 healthcare professionals respond to the call for volunteers. How has the New York health system been able to get these volunteers, many of whom are retired, to where they are needed, and also to make sure they're prepared and protected in dealing with COVID-19?
I guess I'll take this one too. So right now, I think the way the state, Governor Cuomo had made it a lot easier to get credentialed in this state. So if you are a practicing physician of good stance with your license in your particular state, getting a license to work here on a temporary basis really shouldn't be an issue. And at least from the New York Presbyterian side, they have made it particularly open where they can credential themselves into the hospital and get to start working. So I don't think they're necessarily calling on just retired workers that are within the area. They're calling on all types of medical workers. So whether that ranges from being not only a physician or an intensivist, but includes like nurses, medical assistants, technicians. They are being called for to come and work for our system in anticipation for the high volume patients to come. So that's how I guess our systems are dealing with it. I'm not sure how the other systems are doing it, but I imagine that they're probably doing something similar.
Great, thank you. The next question is directed at Dr. Federgruen from another professor, Professor Lorraine Marchand. She asks, can we learn anything from the IDNs in the US like Kaiser and Geisinger and single payer countries like the UK and Germany in terms of their control over the supply chain and transparent information versus the decentralized hospital system in the US? What should the new model look like?
Could you repeat it? Can we learn from whom exactly?
From organizations such as Kaiser and Geisinger in the U.S., as well as single-payer countries like Germany and the UK, right, in terms of their control over the supply chain.
Right. I don't think that the issue of whether one has a single-payer system or not is necessarily relevant and important for this particular discussion. It's a very important discussion to have, but I don't know whether it's necessarily important for this discussion. I am personally a believer that indeed in many areas we can have a very decentralized decision making and it works better, but not in cases where there's a crisis. Just like it doesn't make any sense for individual cities to have their own armies to protect themselves against foreign invaders. And the like, and we have the federal government there with its centralized army to protect us all. This is like a war, and there it does make sense. Now, many companies many companies are practicing responsible supply risk protection and mitigation strategies. Both in the United States and elsewhere. And yes, there are best practices that we can learn from. And we can also learn from bad practices of what has gone wrong. The companies that have literally lost their entire presence in the market because they weren't prepared for supply disruptions. There have been industries where there's a tremendous turnaround because some companies were prepared for, let's say, a component supplier, a chip supplier that is going out of operation for several months, and the whole production in that particular season, the whole sale of that production gets delayed. Such a thing can not only have an impact locally on one single season or one single year, it can have an impact on the entire competitive position of the company in that particular product line. We've seen that in the mobile phone industry, for example, 10 years ago, and there are many other examples. I want to be short and brief because I know there are many other questions. So we can learn from best practice. We can learn from bad practices as well. We see these things happening on the good side and the bad side, both in countries that have a single payer system and in countries that work like we do.
Great. The next question is addressed to Professor Qian from an anonymous attendee. Professor, you mentioned the bottleneck for care is staff. How severe is this bottleneck, and what options are there to solve for this in the short term? For instance, is it possible to have short-term training for lay people to assume some of these roles?
I would say lay people is probably too extreme. The Society of Critical Care has actually put out plans to try to alleviate this bottleneck in a way, and it's a tiered system. Intensivists, you have to go through additional training to be certified to be an intensivist. They would be used to actually supervise over other physicians who are physicians, but maybe don't have a specific critical care training. So they are, equipped to at least be aware of certain issues that are going to come up, but they're being supervised by someone that has a particular specialty. Similarly, for nurses, that would be first you have kind of like a centralized the critical care nurses to help oversee non-critical care certified nurses. So there are these tiered systems that are put into place, but it takes years to get this training, and it's given the timeline of the situation, it's unrealistic to credential up people. That said, there are people are being pulled into different areas based on needs, and I think that there's flexibility. There needs to be flexibility in that place. There may be people who actually had trained as an ICU physician years ago and then switched specialties. Like those may be people that have the better ability to shift and use that those needs. So I think that if you think about it from a tier system, from the physicians, the respiratory therapists, to the nurses, those are our direct frontline employees. Then there's also kind of all the support that goes behind them, and perhaps there's ancillary functions that you can start bringing other people in. And so there's already efforts to do that, but you have to acknowledge that this is not equivalent to having the specialized training for every individual, right?
Right. This next question is more focused on the supply chain. It reads that many people, including our president, seem to believe that this crisis will diminish in the next 4 to 6 weeks. However, many public health officials are now suggesting that rural areas could be overwhelmed with cases in the next 2 to 3 months, and that a second wave of cases could reemerge in urban areas once the social distancing guidelines are lifted. In short, there is an acute supply chain problem, but also a more chronic problem. Is there an effort to address the supply chain problem over different ranges of time?
I guess I'll take that. On a national basis, there is a start of that happening. I know that Dr. Birx is assembling a team of people to, first of all, get a much better visualization of what are the resources that are out there. I think what the government is struggling with, it simply doesn't even have a real good picture about what are the resources available in different places. That as a first step, and then they need to start developing the planning models to protect ourselves better in the future. That effort is starting as we speak. It should have started a couple of years ago, and certainly it should have started 2 months ago. When the alarm bell really should have started to ring. But it is, the good news is it is starting now. I know when another colleague of mine in our DRO division will be heavily involved in it. His name is Professor Bueda. I know that many students have taken courses with him. He will be involved in this effort, directly supporting Dr. Burks in this process.
Great. Speaking a little bit more globally, what are some of the best practices and lessons we've learned from Spain, Italy, and South Korea? And why does it seem like the pandemic is disproportionately hitting the Western world harder? Can you take us to this one?
Actually, Carrie, if you want to take this one, I think this is why don't you take this one?
Okay, you look like you were going to say something, but I can go first, and then you can add.
I was, but then I thought you would add a smarter answer. So,
so I think that we see, there has been, with the outbreaks of the swine flu in Asia, I think that many of the Asian countries were more prepared to recognize that there was a potential for an issue, and so they acted much more rapidly. I think one of the things that South Korea has been very successful at is their testing capabilities, and especially with this particular virus, which is so hard to detect, that there are so many people who are asymptomatic. And that's, I think, really the biggest challenge compared to other epidemics, is that it's propagating and people don't even know that they have it. And so South Korea has been very successful because they're very, very aggressive testing capabilities. I think it was a bit slow in the US and other Western countries because I think perhaps, the potential was a bit underestimated, and there was slow preparation. We actually have seen Germany as being put forward as an example of a Western country that has been very successful. They have lower mortality rates. And again, they have been very proactive, testing rapidly, tracing contacts, aggressive in the quarantine. Going back to your earlier question about, are things getting better in the U.S.? Are there going to be, epicenters now in rural areas or a second wave? It's hard to tell from the numbers. It does seem that we're moving in the right direction, but. I think that we can't be complacent. It's so important for those rural areas. If they become complacent and they think, oh, the cities are fine, so we're going to be fine, that's the wrong way to think about it. It's the cities have gotten through this. We have to prepare. If it's coming here, what should we do? Can we learn from them? And so I think that has to be the lesson coming from this, is that we need to act quickly, swiftly, and aggressively. Yes, some of the measures can be drastic and uncomfortable, but it's better to do it quickly and dramatically so that we can move on from it. And I think that that's kind of the example that we've seen. It took some other places longer to react than others. And so it's really about being proactive in preparing for this.
Great. Well, I think you also, you touched on testing, which I recognize now, and there was just a comment that came up about it. It's sort of testing capacity bridges in between supply chain and also really impacts care delivery. So I was wondering if any of you could speak a little bit to sort of what are some of the challenges to upping the production and mass distribution of test kits, and kind of where we stand on that issue.
Yeah, so I'll take that one. So the testing has always been kind of a touchy issue, because I think in the ideal setting, everybody would get tested, just like the way South Korea has done it. But, we run into a lot of issues because initially when we're testing patients, we were swabbing the nose, swabbing the throat. And then soon what we begin to realize is that as the number of suspected cases, patients under investigation for COVID was increasing, we actually were running out of space in the machines to actually do the testing. And we were initially sending them all to the Department of Health, which was not a very scalable solution. So when we were able to finally start scaling up on the machines, and when Roche got their machines sent out and they were able to do rapid testing, the other limitation soon became the actual medium, the fluid, the swab, but the fluid actually became the limitation. So it was an interesting lesson, because I think there were things that in our mind that we didn't, at least as physicians, we don't really think about them. We think that there's a whole abundance of them. So this had led to kind of a lot of adjustments in the way we treat our patients. So this led to a lot of ways how we test our patients. And of course, it led to a lot of potentially, the counts were skewed. Probably weren't skewed in the sense that everyone who got discharged, nobody really got tested. So the actual count of the number of COVID cases is actually unknown, and we can only make a guess. So it's been interesting trying to treat this from an epidemiology perspective and a public health perspective. But so again, I guess the best way to phrase it's been interesting.
Great. Well, I would love to ask many more of these questions, but I think I'm about to get the hook because we are actually just a bit over time. I really want to thank all of our panelists, Professor Qian, Professor Federgruen, and Dr. Park. Thank you so much for taking the time to be on here, and thank you to the audience for submitting these questions, and thanks to the folks at Columbia Business School for helping coordinate and making all this happen. Wishing everyone a wonderful evening, and stay safe and well-stocked. Look forward to a future events such as these in the coming weeks.
Thank you.
Thank you very much.
Thank you. Thank you.